Jorge, can you discuss some of the risks and benefits, toxicity profiles of Bosutinib versus Ponatinib in patients with relapsed refractory disease?
Well, that comparison becomes particularly relevant when we consider that in the third-line setting, those are the two drugs that have prospective data clinical trial. In the Bosutinib study that led to the approval in the salvage setting, there was a cohort of patients that had received prior imatinib and either dasatinib or nilotinib, resistance or intolerance. And of course, the Ponatinib study was specifically for patients who had received at least 2 tyrosine kinase inhibitors or more. There were a few patients that had received only one because they had the T359, but overwhelmingly it's 2 or 3 or more tyrosine kinase inhibitors. So that's where that comparison becomes important. And I think what you see there is that in terms of efficacy, if you just look at the raw data, and of course these are different studies and you can look at differences in population, but just looking at the raw data, the response rate with Ponatinib is much higher. I mean, the major cytogenetic response is 60 to 70%. Even if you take away the T359, because of course we know Bosutinib doesn't work there. Okay. But then even then, it's a good 60, 65%. With Bosutinib, it's about 40%. It's nice to have that, but there is a difference there. So I think in terms of efficacy, the third line is well, and let's not forget that the Ponatinib has a number of patients that have received 3 or more tyrosine kinase inhibitors. Here we're talking about 2 prior tyrosine kinase inhibitors prior only in the Bosutinib study. So efficacy-wise, there's clearly an advantage there. There's been some statistical comparisons and all of that, but I think it is we can see that difference both in putting these studies side to side and clinically. I think it is fair to say. Now you asked about the safety, and well, the big difference there is the arterial-occlusive events, and whether there's the Ponatinib has that's where we started seeing those risks, and then we recognize that it happens with other tyrosine kinase inhibitors, but probably Ponatinib has it more than others, and if anything, of the second generation TKIs, Bosutinib has the lowest risk, although we have seen them reported at least. So obviously what's important here is that I mentioned that Ponatinib is a great drug, and I use it. I'm not afraid of using Ponatinib in the right patient. A patient that has had 2 or 3 TKIs. I mean, if I have to use Ponatinib, I'm going to use Ponatinib. I may start with a lower dose. If they have comorbidities, I'll manage them. Now, there are patients that have way too many comorbidities, and well, it's good to have Bosutinib, and there are patients that I'm going to use with Bosutinib. But I think that in the right context, in that third line and certainly more, Ponatinib is the most effective drug.
So that's what I hear you saying. Patients who do not have cardiovascular risk factors, based on the efficacy, you would use Ponatinib or Bosutinib. As long as I'm on that topic, let me ask you one other thing. Have you ever used Ponatinib in order to get a patient into a deeper remission for a treatment-free remissions?
No, I have not. But what I have done is on some of my patients on the PACE study have gotten such a good response that I have 3 or 4 patients that have stopped therapy. They had a great response, and I mean, it's 3 or 4 patients, but they're maintaining the response. So it's definitely doable because you can get to those responses.
Okay, so what I heard you saying there then, if there was a clinical indication for switching to Ponatinib, such as in the PACE trial, then that might actually become an option. But for a patient who's meeting all the milestones and is just interested in a treatment-free remission, you think there might be other options to get them there besides Ponatinib?
Yeah, and there's been, and it probably would work. I mean, let me put it that way. It probably would work. We haven't done it, but it probably would work. We've seen it with nilotinib. There's been an intentional study that's called an SCMR, where patients on imatinib, you put on nilotinib, and some of them, not everybody, but some of them do get to that milestone. I'm sure that if we did the same thing with Ponatinib, we'll get that many or more. We haven't done it, and again, you always have to calculate that risk-benefit ratio, but certainly I think that that could happen.
Okay.